RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers. I'm your host, Amanda Mixon, and president of RhAPP, and today we're going to kick off our EULAR Osteoporosis RhAPP Up Series. Throughout this three-part series, we'll be breaking down some of the most important and practice-changing data coming out of the 2026 EULAR Congress. For today's episode, I'm excited to be joined by Wendy Simmons. Wendy is a prominent RhAPP board member and a beloved guest of our podcast. Wendy, I think our listeners know you pretty well, but before we begin, is there anything that you'd like to start with?
Thank you for having me here for the podcast. I'm really excited, very passionate about osteoporosis in bones, so ready to get started. Thank you, Amanda.
Awesome. Well, let's go ahead and just get right into it. We have a lot to cover. So we will go ahead and jump into part one. So I will go over abstract 1, AB 0544, which is impact of a rheumatology-led bone specialist clinic on guideline compliance and the prevention of clinical fractures in glucocorticoid-induced osteoporosis. An overview of this study. This was a real-world observational study evaluating how a rheumatology-led bone specialist clinic impacted adherence to the 2022 ACR glucocorticoid-induced osteoporosis guidelines and estimated the potential reduction in fracture risk associated with optimized treatment strategy. The background for this study was that glucocorticoid-induced osteoporosis is a major cause of fragility fractures in patients with rheumatic diseases. Updated ACR guidelines recommend risk-stratified treatment approaches, including anabolic therapies for a very high-risk patient, but real-world implementation remains inconsistent. This study aimed to determine whether specialized rheumatology-led bone clinics improve guideline adherence and potentially reduce fracture burden in high-risk populations. The methods were investigators analyzed data from a prospectively collected osteoporosis registry, including patients with rheumatic diseases and current or prior glucocorticoid exposure, evaluated between 2022 and 2023. Fracture risk was classified according to the ACR 2022 criteria using clinical history, bone density, fracture history, and FRAC scores. Guideline adherence was evaluated before and after specialist assessment. For very high-risk patients newly started on therapy after specialist evaluation, Monte Carlo modeling was used to estimate the number of clinical fractures potentially prevented over 10 years. Among the 259 patients, 86% were classified as high or very high fracture risk. Overall adherence to ACR GIOP guidelines improved substantially following specialist evaluation, increasing from 54% before evaluation to nearly 89% afterward. Improvements were especially pronounced among high and very high-risk patients, where adherence exceeded 90% after treatment optimization. Modeling suggested that optimized treatment strategies could prevent nearly 8 clinical fractures per 100 very high-risk patients over 10 years. The greatest estimated fracture reduction occurred with anabolic first treatment approaches, followed by anti-resorptive consolidation therapy compared with anti-resorptive therapy alone. The authors' conclusions were that rheumatology-led bone specialist clinics substantially improved adherence to evidence-based glucocorticoid-induced osteoporosis guidelines and were associated with meaningful projected reductions in fracture risk amongst very high-risk patients. These findings highlighted the important role of specialized rheumatology care pathways in translating osteoporosis guidelines into improved long-term patient outcomes. All right, Wendy, I'm very interested to hear what you think of this study.
Absolutely. And I love it. I ever since being in rheumatology, have always realized and recognized, that there's patients that we treat, and especially with that use of steroids that we have. And it is in rheumatology that we do pay attention to steroids. I know there's multiple other disciplines that have patients on steroids. Certainly, osteoporosis has not been always on the top of everybody's first checklist to evaluate, and that leaves that importance as it shows here in this abstract of reviewing those ACR guidelines and that importance of using those, especially where we are in the rheumatology clinical setting. And I think it's with us in rheumatology, treating osteoporosis, following these guidelines is going to help educate, all others that are with patients that they're using corticosteroids and then having to evaluate osteoporosis. I feel that early on, as it talked about in the abstract, uh, want to highlight the importance of, clinical evaluation, that clinical history of the patient is also so very important. As we also see here in the abstracts, not just the history, we're combining that bone density. So it's not one isolated unit of measurement that we're using here. We're using that clinical history. We're using the DEXA guidelines. What are those T scores? And then, has that patient fractured? What is that history? Which we found is so important to keep in mind here as well. But then also the FRAX scores. And as we know, FRAX scores actually include as a risk factor that glucocorticoid therapy. You take that alone in these patients, and then you add the disease state in of rheumatoid arthritis, and perhaps they might have another risk in that clinical history you pick up on. And wow, you calculate that FRAX score, and that really puts them at a high risk. So I like that part of, correlating those ACR guidelines to tie into what we should be doing in these patients for evaluation as well. Uh, the mention here as well in that abstract, once we've done all that with these patients on steroids, finding out that high risk and what we need to do with them. The mention here of the importance of, looking at what approaches we are going to take for the treatment. That's another big educational factor here, I believe. And really looking at the data here with reducing that great fracture risk by stepping in with anabolic first treatment therapy. I believe looking and further evaluating this abstract really does show us sequencing, the beginning of a sequencing. We need to understand that. That's still something that I feel needs to be well educated for these patients. We do a great job. I think we're doing much better. Certainly also in rheumatology is anabolic first treatment approaches, then followed by that antiresorptive therapy as well. And it looks like, from this data that is showing the important role of what we're doing in these pathways. The impact on our patient care is tremendous. I feel that even myself, seeing less fractures in those, age 70 age population. I feel that if we pay attention to what this abstract is showing and do those evaluations sooner rather than later, being able to choose that sequence of therapy as we can appropriately for the patient, that we are definitely going to have a huge impact on the patient care as they have their future, even after the steroid therapy as well.
What's so true, and I think, what this highlights to me is that we really do need people that know what they're doing, I mean, because so many people treat osteoporosis, whether it be primary care, endocrinology, sometimes orthopedics, certainly rheumatology. So having these rheumatology led bone specialists that know the guidelines, adhere to the guidelines. I think just it doesn't surprise me that then the adherence is higher, the compliance, utilizing those anabolics like you recommended as a first line. I think again, all of those things are so important because not everybody knows what we should be doing, right? I mean, I certainly have seen people that, come for kind of a second opinion for osteoporosis and they've already fractured and they're just on a bisphosphonate. And so, I think understanding that having that kind of extra um extra education and knowing how to treat these patients, I think, certainly seems to make a difference.
Amanda, you have made the absolute best major point here as well. I completely agree. I see so many of my patients, in our rheumatology clinic, but I also see all the disease states. So being able to see what happens in rheumatology, we love labs. We love to dig in deeper, take that deeper dive. So to your point, all other, disciplines that are treating it, I feel they definitely need to be educated as well because they might be seeing an ortho or primary care or even women's health, GYN. I get a lot of referrals. Some of these patients that might be crossing their paths as well, might have pulmonary issues. They might be on steroids from another discipline. And so I think this is really where it can become a multidisciplinary, treatment. I feel that referring to a rheumatology clinic is absolutely appropriate. We've definitely gotten really busy. I'm, with 4 doctors and they are all also doing osteoporosis. We treat our own patients. So it's not like they treat disease state and send osteoporosis to me. We've all together been looking at this as well. So it's great to be able to educate everyone and, be able to explain why we're reducing the fracture risk. I'm also seeing, many more patients coming in from the primary care setting. And also, again, to your point, it's not osteoporosis is not something that a lot of these other disciplines can put at the top of their list for their patients. It might be a matter now of checking that they've had done a bone density on the patients, but also putting the time into evaluating that bone density and looking where the T scores are and then taking those extra steps for calculating the FRAX scores. That does take time. And again, back to your point made, these patients I feel are better served sometimes in a rheumatology setting as well. We certainly can turn these patients back over to their primary care or whoever referred them for a consult. So great value shown here in this abstract that you've presented in the deep dive that we do take in the rheumatology setting, and most particularly having paying attention to the glucocorticoid patient because multidisciplines do treat as well. So these patients are not only the ones we're treating; they're all over in multiple disciplines, and might end up. I've seen patients that see a primary care, they might see pulmonary, have steroids, but then they might end up seeing the orthopedist with that fracture, and then they come to rheumatology. So excellent presentation, great abstract. I love that.
Yeah. All right. Do you want to talk to us about an abstract?
Yeah, so we're going to move on to our abstract 2, AB0556, Treat to Target Approach in Osteoporosis, a real-world comparison of teriparatide and denosumab. And I love this. We're going to go through this, but this is something that we all see and also, again, needs to be reviewed throughout a lot of disciplines. So with the overall view of the study, this real-world observational study evaluated whether patients with osteoporosis treated with either teriparatide or denosumab achieved a predefined treat-to-target goal of improving their bone mineral density to a T-score that's greater than minus 2.5, while comparing the outcomes between that anabolic and antiresorptive therapy. The background purpose in this abstract shown is that the treat to target strategy has recently emerged in osteoporosis management with the goal of individualizing therapy around measurable treatment targets rather than simply initiating medication. The bone mineral density measured by the DEXA-derived T-score is currently the most practical target because of its strong relationship with the fracture risk. However, there's limited real-world evidence demonstrating how often these targets are achieved or whether the anabolic or antiresorptive therapies differ in their ability to reach them. The methods used here are shown with the investigators performing a retrospective observational study of 44 patients with osteoporosis that were treated at a single rheumatology center. Patients received either the teriparatide for 18 to 24 months or denosumab and had baseline and follow-up DEXA score scans over about approximately 2 to 3 years. The skeletal site with the lowest baseline T-score served as each patient's treatment target. Primary outcomes included achieving a T-score greater than minus 2.5 among the patients below the target at baseline, while secondary analysis evaluated bone mineral density changes, site-specific outcomes, and factors associated with treatment response. The results: most patients entered the study with severe osteoporosis and prior fragility fractures. Overall, attainment of the predefined treatment target was modest, occurring in 17.6% of teriparatide treated patients and 36.4% of denosumab treated patients. Although this difference was not statistically significant, the lumbar spine demonstrated the greatest improvements in bone mineral density in both groups. After adjustment for baseline characteristics, treatment type was not independently associated with greater BMD improvement, suggesting similar overall effectiveness between therapies. Fragility fractures during follow-up were uncommon, regardless of treatment strategy. The author's conclusion here: in routine clinical practice, achieving a predefined treat-to-target goal for osteoporosis remains challenging, even with modern anabolic anti-resorptive therapies. While both teriparatide and denosumab improved bone mineral density, neither demonstrated superiority after adjustment for clinical factors. Larger studies are needed to do better define how treat-to-target strategies should be implemented and optimized in osteoporosis management. This is very important. Number one, from the standpoint, treat-to-target is where we're going now. That's really still what we need to be learning, what we need to be thinking in our patients. To the point here in this abstract, we want to have patients that we're going to be able to improve the bone mineral density, reduce the fracture risk, get that T-score higher than minus 2.5 as well. Teriparatide and denosumab are two great medications, well-used medications. And again, this really potentially will go back to our thoughts on sequencing therapy, building bone, then remodeling bone. How are we going to use these therapies? Certainly in what order? As pointed out here also that I notice in the abstract, this wasn't to promote any type of superiority or inferiority of either one of these medications as well. And also pointed out here in this study with the abstract of these patients was looking at also clinical history of that patient. We know that our osteoporosis patients are unique. One isn't the same as the next patient. There could be multiple reasons as to why you would see certain results with one medication in one patient and not another. And those definitely would have to be taken into consideration as well. Length of time of treatment is important. Sequencing certainly is important. And ultimately, we don't have visualization of that skeletal matrix. We're not able to see that. This is really as close as we can get here as well. I'm sure that you're seeing patients in clinic as well that either you have to make those choices of what am I going to choose, what's best for the patient. And it is helpful to look at an abstract like this as well.
Yeah, I totally agree with you. I think this is highlighting, to your point, kind of this treat to target approach. And, we've had that with rheumatoid for so long, but, I guess I haven't really thought about it in osteoporosis, and I think, we need to because just like with everything else, right? Like with rheumatoid arthritis, we say, the longer you take, the more damage is done. And I think it's the same with osteoporosis, right? The longer that we take to not put that person on therapy or the right therapy for that patient, potentially then they fracture. And obviously we know particularly certain fractures in elderly patients can lead to a high mortality. And so I agree. Obviously, larger studies are needed to kind of understand this a little bit better and define what treat to target actually means. But I totally agree. We need to be thinking about that in our osteoporosis patients.
Absolutely, and I feel that they have shown that point here, certainly,
Yeah.
in this abstract. It's great to put this out. It serves also a great purpose of education for all of us, and those that are treating osteoporosis. And these patients are tough. They can be unique. They can be certainly complex as well. They can be of certain ages, depending on that history or any of their risk factors. I do feel that it does bring us again back to thinking about what types of therapies we have in our toolbox, which we have excellent therapies, what order that we can use these therapies in, what populations we can use these therapies in. Can we reuse any of these therapies? Starting points, stopping points. It really all enters into this as well. Then also, as that patient is maybe potentially an aging patient, looking at spine densities, and even hip density measurements. If osteoporosis patients have an element of osteoarthritis coexisting as well, that can falsely elevate some bone mineral density. What is that doing to the T scores as well? So that has to certainly be taken into consideration. To your point that you mentioned, certainly there was a smaller population with this abstract that was observed, but it's great. It makes us think. Hopefully, certainly other studies, other populations will be evaluated, but most importantly, that treat to target strategy being emphasized in whatever setting that we are in, treating to our patients with osteoporosis. I think that's well covered for sure.
Well, great. Thank you so much for your insight, Wendy. It's always very appreciated and needed. Well, that wraps up part 1 of our EULAR Osteoporosis Wrap Up. Be sure to join us for part 2, where we will continue to break down the most relevant updates from EULAR 2026. See you next time.